Welcome back to the deep dive. Today, we are undertaking a really critical look into the architecture of movement itself, rheumatology and bone disease.
Mhm.
And it might surprise you to learn that clinically, this system, the musculoskeletal system, is the single largest source of physical disability on the entire planet.
Staggering, really.
We're talking about conditions that just profoundly impact quality of life, accounting for, well, about a third of all long-term physical disability worldwide. So if
Yeah.
you're a student getting ready for your clinical years, this field is, well, it's non-negotiable, but it is notoriously complex to master.
Precisely. And our mission today is to cut right through that complexity. This entire deep dive is custom-tailored. It's distilled primarily from the essential concepts you'll find in Chapter 26 of Davidson's Medicine.
Right.
We're not aiming for just a textbook reading here. Our goal is to help you build what we're calling sticky knowledge. We'll provide you with clear metaphors, critical clinical anchor points, and the synthesis you need to make this dense material, things like the molecular language of bone remodeling or the physics of crystal analysis, just snap into place for rapid recall.
Both in an exam and, more importantly, when you're standing in front of a patient.
Exactly. That's the goal.
I love that idea of sticky knowledge. So we're going to build this knowledge structure from the ground up. Let's start with the absolute foundations. We're calling this section the blueprint.
Good place to start.
Before we can really understand what goes wrong in disease, we have to grasp the incredible dynamic complexity of the building materials themselves. The bone, the joints, and the muscle attachments.
So let's dedicate our first few minutes to bone itself, which is so far from being a static scaffold. Think of it, like you said, as a continuously managed dynamic skyscraper.
Yeah.
And when we talk about how that skyscraper gets built, how bone develops, we really distinguish between two fundamentally different processes.
The first one, intramembranous ossification, is kind of the direct route. This is mostly how your flat bones, like your skull or your clavicle, are formed.
Right.
You have these mesenchymal stem cells in the embryonic connective tissue, and they differentiate directly into bone-forming cells, the osteoblasts, without any kind of cartilage model in between. It's a rapid way to lay down bone tissue right away.
And then you have the more complex, sort of slow burn method. Endochondral ossification. This is how the vast majority of your weight-bearing bones, your long bones like the femur and the humerus, develop.
Okay.
It begins when those mesenchymal cells first form a hyaline cartilage template, a little model of the bone.
A blueprint.
A perfect blueprint. This template is then gradually invaded by vascular tissue, ossification centers appear, and that cartilage is meticulously replaced by bone tissue over time. What remains of it, that thin layer of cartilage at the ends of the long bones, is the epiphyseal plate.
The growth plate.
The growth plate, exactly. And that's crucial for longitudinal growth until the process is finally halted by sex hormones during puberty.
And once it's built, we look at the final structure. You've got this dense outer shell, the cortical bone, which provides all the mechanical strength and forms that hard envelope of the long bones. And this is highly organized into these cylindrical units called haversian systems, or osteons, that run parallel to the axis of the bone.
And then inside that dense shell filling the interior, you have the trabecular bone or cancus bone. This is the internal scaffolding. It's this delicate interconnecting meshwork of bony struts or trabeculae, and the spaces in between are filled with bone marrow.
Has a really high surface area, right?
Huge surface area. And it's structurally optimized to handle all those compressive forces. Because of that high surface area and porous structure, trabecular bone is also metabolically much more active than cortical bone.
Which means
Bone turnover is much higher here. And that makes it the first place to suffer during pathological bone loss, like an osteoporosis. It's the first to go.
this high turnover brings us right to the core concept of bone pathology and physiology, the bone cell construction crew. This crew has to operate in a perfect dynamic balance. If the system tips too far one way or the other, you get disease.
Right. Let's break down the three critical roles using our construction site metaphor.
Okay.
First, you have the osteoclasts, the demolition team. They were specialized, large, multinucleated cells, and they're derived from hematopoietic stem cells.
The same line as monocytes and macrophages?
Exactly the same lineage. Their entire job is bone resorption. They achieve this by sealing themselves off to the bone surface, creating something called a ruffled border, and then they secrete this potent cocktail of hydrochloric acid to dissolve the mineral, the hydroxyapatite.
And enzymes for the protein part.
Yes. Proteolytic enzymes like cathepsin K to degrade the type I collagen matrix. They're the ultimate efficient recycling unit.
Okay, so that's demolition. What about the builders?
Number two, Osteoblasts. The construction crew. These are derived from marrow-stromal cells, so the same lineage as fat and cartilage cells. They're responsible for bone formation.
So what do?
They first synthesize and secrete the initial uncalcified organic matrix, which we call osteoids, like the rebar.
Yeah.
Only after they've laid down this matrix do they then orchestrate the mineralization process, depositing the hydroxyapatite crystals onto that framework.
And the third member of the crew, the most important one, maybe.
Maybe the most important. Number 3, osteocytes. The site managers. These are actually former osteoblasts that have become entombed within the very matrix they laid down. They are incredibly numerous, and they form this intricate dendritic network connecting to each other and to the bone surface.
And their function is profound.
It is. They are the mechanosensors. They are the ones that sense the mechanical forces, the stresses and strains applied to the bone, and they coordinate the entire formation and resorption process in response to that. They're the brains of the operation.
It's amazing to think about the building materials they're working with. The bone matrix is essentially a highly engineered composite material. The flexibility and tensile strength, the ability to resist being pulled apart, that comes from the organic component, type I collagen.
Right.
And that collagen is cross-linked by these special molecules called pyridinium molecules, which dramatically enhance its mechanical robustness.
And then the rigidity, the compressive strength, that comes from the inorganic component, hydroxyapatite. These are the calcium and phosphate crystals deposited within that collagen framework. This combination of collagen and mineral is what makes bone so incredibly strong, yet slightly flexible.
Right.
Now, quick clinical detail here. When bone turnover is extremely high, or pathological, say in the accelerated stages of Paget's disease or hyperparathyroidism, the osteoblasts lay down bone really quickly and chaotically.
It's not organized.
Not at all. It lacks that orderly lamellar structure. This mechanical weak bone is called woven bone, and it's the hallmark of disorganized, fast turnover.
So now we get to the regulatory command chain. This is the molecular language the construction site uses to coordinate all that formation and demolition. This section is dense, but I think once you master these 3 key signals, the whole system just unlocks.
This is a critical molecular anchor point. It's often tested because it explains so many disease mechanisms and so many of our drug targets. The rate of bone resorption is governed by the osteocytes and stromal cells talking to the osteoclasts.
And they use 2 main signals.
They do. First, ARANKL. That stands for receptor activator of nuclear factor kappa B ligand.
A mouthful.
It is. So just think of RNKL as the go signal for the demolition team. It's produced by the site managers, the osteocytes, and when Ankel ball binds to its receptor, which is called rank on the osteoclast precursor, it promotes their maturation, their activity, their survival. It just leads to more bone resorption.
But there has to be a break.
There is. The second signal is OPG, or osteoprotogerin. This is the natural inhibitor. It's a decoy receptor.
So it tricks ARN.
Perfectly put. It's produced by stromal cells, and OPG just binds to NKL, preventing our NKL from ever reaching its receptor on the osteoclast. It effectively slams the brakes on osteoclast activity. The ratio of our NKL to OPG is the central determinant of net bone loss.
Okay, so that controls the demolition side. Now, how do we regulate the construction side, the osteoblasts?
That's managed by the third major signal, sclerostin, or SOST. This signal puts the brakes on the construction crew. It's produced almost exclusively by the site managers, the osteocytes, and SOST is a powerful inhibitor of bone formation, specifically by blocking the Wnt signaling pathway.
Okay, let's pause right there because the Wnt pathway is huge. For the learner out there, why is blocking Wnt such a big deal for bone?
Think of Wnt signaling as the master switch for osteoblast activity. When Wnt signaling is active, it stabilizes a protein called beta-catenin inside the osteoblast.
Right.
Beta-catenin then travels to the nucleus and starts transcribing all the genes that are essential for bone matrix production and maturation. When sclerostin comes along and blocks Wnt, it prevents that beta-catenin stabilization, effectively shutting down construction. So sclerostin is the osteocyte's way of saying, okay, stop building.
And this is where the genius of the osteocyte, the site manager, really shines. It links that physical force to biological function.
Exactly. Under conditions of mechanical loading, when you walk or run or lift weights, the physical stress is sensed by the osteocytes, and this stress inhibits sclerostin production.
It turns off the stop building signal.
Exactly. Removing sclerostin removes the brake on the Wnt pathway, and that allows the osteoblast to rapidly ramp up bone formation right in the area that's being stressed. Bone adapts precisely where it's needed.
And conversely, if you're immobilized, the mechanical stimulus is gone, and the osteocytes perceive that bone is no longer needed in that area. SOST production ramps up, and bone formation shuts down. So we could already use this knowledge clinically. Let's do a little check-in question right here. Imagine you have a patient who is post-stroke and completely paralyzed on one side, or maybe they've been bedridden for weeks due to a severe infection. They're completely lacking that normal mechanical stimulus. What happens specifically to their sclerostin, their SOST production, and what is the resulting pathological effect on the bone in their affected limbs?
The answer is absolutely crucial for understanding critical care pathology. What happens is SOST production increases dramatically because that mechanical inhibition is released. This overproduction shuts down the want signaling pathway, which shuts down bone formation. This mechanism is a powerful contributor to immobilization-related bone loss and atrophy. So if you're struggling with that dynamic interaction between mechanical force, SOST, and Wnt, please rewind and listen to this command chain segment again. The rank-optious relationship is absolutely foundational to understanding bone therapeutics.
Okay, so the key takeaway for bone. Bone strength relies on the dynamic, coordinated balance between the demolition crew, the osteoclasts activated by Rankel L, and the construction crew, the osteoblasts activated by Wnt. This entire cycle is regulated by the site managers, the osteocytes, primarily via the mechanical sensing of sclerostin, or SOST, which functions as the stop building signal.
Perfectly summarized.
Now that we've built the scaffolding the bone, let's pivot quickly to the articulation points, the joints and muscles.
Structurally, we classify joints into three types. Fibrous, which have minimal movement like skull sutures. Fibrocartilaginous, with limited movement, often involving a shock-absorbing disc like the pubic symphysis or the intervertebral discs. And the crucial one, synovial joints.
And synovial joints are the focus of rheumatology because they permit large movement and are lined by that specialized membrane.
Exactly. And the articular cartilage covering the bone ends in a synovial joint is really the star of the show. It's a remarkable tissue. It's avascular, which means it gets no direct blood supply. It's just chondrocytes embedded in the matrix. The perfect metaphor here is the articular cartilage as the wet sponge.
I like that.
And this is why it's such an effective shock absorber. The matrix is a mesh of robust type 2 collagen fibrils. That's the container. And that container is holding a highly hydrated gel of aggrecan proteoglycans.
But what's so special about aggrecan?
Aggrecan is densely packed with negatively charged sulfated groups. This strong negative charge avidly binds massive amounts of water molecules, creating this intense expansive pressure inside that collagen mesh.
So the collagen mesh acts like a tight net that's restraining these water-attracting aggrecan molecules. The magic of shock absorption happens when you compress the joint. Water gets squeezed out, acting as a hydraulic damper. When the load is released, the negative charge of the aggrecan pulls that water right back in, which effectively feeds the chondrocytes and maintains hydration.
That's spot on.
Yeah.
And the tragedy of aging and osteoarthritis is that as we get older, we lose some of the aggrecan's capacity to bind water.
The sponge starts to dry out.
The sponge dries out, you get reduced hydration and diminished shock absorption, which leads to cartilage fissuring and eventual breakdown.
Inside that joint cavity, we find the synovial membrane and fluid. The membrane has two types of cells, or synoviocytes. Type A, which are phagocytic and act as the joint's internal cleaners, and type B, which are fibroblast-like cells that secrete the key fluid components.
And the synovial fluid itself is basically an ultrafiltrate of plasma plus hyaluronan, which is this massive glycosaminoglycan that's secreted by the type B synoviocytes. It's responsible for the fluid's characteristic viscosity and lubricating properties, absolutely essential for frictionless movement.
And finally, we have to briefly anchor the muscle attachment site. The emphasis is the specific location where a tendon or ligament inserts directly into the bone surface. The site is structurally distinct and highly specialized, and clinically, this is a major inflammatory hotspot enthesitis.
Enthesitis. And it's a hallmark feature of the entire group of diseases we call spondyloarthritis, or SPA, things like ankylosing spondylitis and psoriatic arthritis.
Right, so the key takeaway for joints. Cartilage shock absorption relies on the expansive force of water binding to negatively charged aggrecan, constrained by that type 2 collagen mesh. And remember that the emphasis is the common target for inflammation in the spondyloarthropathies, or SPA. Right. Now that we understand the blueprint, let's pivot from basic structure to how we find out what's broken when a patient walks in the door. The clinical examination is still your most powerful diagnostic tool.
That's right. A structured, efficient examination is absolutely vital. We use screening tools like the GALS screen, which stands for General Assessment of the Locomotor System.
And that lets you quickly assess function.
Very quickly, we look at key assessment points,
Yeah.
inspecting the gait for any abnormality, evaluating spinal mobility using tests like Schober's test, which measures lumbar flexion, and, crucially, screening for early subtle synovitis.
And what's the most high-yield way to check for early synovitis in the hands and feet?
The squeeze test. Gently but firmly, squeezing the metacarpals in the hand and then squeezing the forefoot to check for pain over the metatarsophalangeal joints, the MTPs. Tenderness here is often the very earliest sign of an inflammatory arthritis like rheumatoid arthritis.
Observation is another goldmine. Specific visual cues can instantly narrow your differential diagnosis. A classic example, the bilateral symmetrical butterfly rash or malar rash that spares the nasolabial folds.
That screams SLE.
Systemic lupus erythematosus, yeah.
Or consider the hands. Hard, bony swellings on the distal interphalangeal joints, the DIPs, those are Heberden's nodes. And on the proximal interphalangeal joints, the PIPs, those are Bouchard's nodes. Both are just pathognomonic for osteoarthritis.
You have to look at the nails, too.
You have to. Nail pitting, onycholysis, which is nail separation, or those little oil spots, are strong clues pointing towards psoriatic arthritis, PSA, even if the skin psoriasis is minimal or completely absent.
And of course, the classic rheumatoid nodules, usually found over extensor surfaces like the elbows. And if the patient's main complaint is just widespread, nonspecific pain and fatigue, you should look for focal areas of hyperalgesia, the specific tender points, which strongly shifts your thinking toward fibromyalgia.
Now, moving from the bedside to the lab, one of the most critical diagnostic procedures, a true medical emergency in the joint, is synovial fluid analysis. This is triggered when you encounter acute monoarthritis, acute pain and swelling affecting a single joint.
And the anchor rule here is simple, and you cannot forget it. Joint aspiration is mandatory in all individuals presenting with acute monoarthritis until septic arthritis is excluded.
Mandatory.
Septic arthritis is a destructive, time-sensitive emergency. You have to aspirate even if you strongly suspect something else, like gout.
The fluid characteristics tell a complete story. Normal synovial fluid is low volume, crystal clear, and highly viscous. It'll string out between your fingers. With inflammation, three things happen. The volume increases. The cell count, especially neutrophils, rises dramatically, which causes it to become turbid or cloudy, and critically, the viscosity reduces.
Wait, why does the viscosity drop? That seems a little counterintuitive.
It drops because the inflammatory process, specifically the neutrophil activity, releases enzymes that just degrade the essential components, primarily the long chains of hyaluronan and aggrecan.
So it breaks down the lubricant.
It breaks down the lubricant. When those lubricating and viscosity imparting molecules are broken down, the fluid becomes watery. Turbid, watery fluid with a cell count over 50,000 cells per cubic millimeter is a huge red flag for septic arthritis, though crystal arthritis can also give you a high count.
But the true instant diagnosis comes from crystal identification using compensated polarized microscopy. This instantly differentiates gout and CTPD. We need to nail the birefringence.
Let's cement those mnemonics right now. First, gout, which is monosodium urate or MSU. The crystals are long, thin, and classic needle-shaped structures. They display negative birefringence.
Which means they appear yellow when they're aligned parallel to the compensator axis.
Right, our anchor remains. Gout makes you feel negative, or needles are negative.
Okay, and the other one?
The other one is CPPD, calcium pyrophosphate dihydrate. These crystals are smaller, typically rhomboid or brick-shaped. They display positive birefringence, meaning they appear blue when aligned parallel to the compensator axis.
Anchor for that.
Calcium is positive, or rhomboids are robustly positive.
Getting that right under pressure is absolutely essential. Now, moving to imaging and serology, let's discuss bone mineral density assessment, the core diagnostic tool for osteoporosis. We use DXA scanning or dual X-ray absorptiometry.
DXA measures BMD in the hip and spine. The results are presented as the T-score, which compares the patient's BMD to the peak bone mass of a healthy young adult, about a 30-year-old. This is the standard for diagnosing osteoporosis because it predicts fracture risk independently of age.
And the anchor definitions are?
Osteoporosis is a T-score less than or equal to no negative 2.5 standard deviations below the peak. Osteopenia is a T-score between the negatives 1.0 and a negative 2.5, and normal is a T-score above negatives 1.0.
And let's talk about those general markers of inflammation. C-reactive protein, CRP, and the erythrocyte sedimentation rate, ESR. While they're generally raised in inflammatory disease, the COP-ESR disconnect is a massive clinical anchor you cannot forget.
This is such a high-yield differential point. If you are dealing with active autoimmune connective tissue diseases like systemic lupus erythematosus, SLE, or systemic sclerosis, the ESR is often raised because of hypergammaglobulinemia, high antibody levels. But the CRP is typically normal or only mildly elevated.
So what does that mean clinically?
It means that finding a highly elevated CRP in a patient with known SLE or scleroderma is a critical clinical red flag. It suggests an intercurrent illness, like an infection or sepsis, rather than a flare of their underlying autoimmune condition. It completely flips the diagnostic interpretation.
Wow. Okay, finally, autoantibodies. They provide the identity tags for autoimmune disease. We start with anti-nuclear antibodies or ANA.
ANA is the ultimate screening test. It has high sensitivity, meaning it rarely misses an autoimmune disease, but it has low specificity.
It appears in a lot of conditions.
A lot of conditions, and low titers are actually common in healthy individuals.
Hmm.
So if the ANA is positive, we then move to more specific tests.
Okay, so we have all these autoantibodies. But if I'm a student seeing a patient with suspected autoimmune disease, how do I avoid just checking all of them? Is there a hierarchy here, maybe starting with the high sensitivity ANA before moving to the high specificity markers?
That's an excellent point. And yes, there's absolutely a hierarchy. You use the ANA to rule out low probability disease. If it's positive, you move up the hierarchy. For SLE, the high specificity comes from anti-dsDNA antibodies and anti-lipsome antibodies.
And the dsDNA is particularly important.
Very important. High titers of anti-dsDNA are associated with more severe disease, especially lupus nephritis, which is kidney involvement. For rheumatoid arthritis, we use rheumatoid factor, RF, and anti-citrullinated peptide antibodies, ACPA. RF is nonspecific. You can find it in other conditions. ACPA, however, is highly specific for RA, and it's predictive of erosive disease. That specificity makes it the preferred marker.
Let's check in on the overall diagnostic picture now, applying our knowledge of basic chemistry. A 65-year-old patient presents with new-onset widespread chronic pain and fatigue, but the physical exam is unremarkable except for diffuse tenderness. You order blood tests and you find entirely normal results for calcium, phosphate, and alkaline phosphatase. What common generalized pain syndrome is strongly supported by these unremarkable lab findings?
The complete lack of laboratory abnormalities, coupled with that history of widespread pain and fatigue, strongly points to fibromyalgia, or possibly hypermobility Ehlers-Danlos syndrome.
Right.
In fibromyalgia, investigations are characteristically unremarkable. All inflammatory and biochemical markers are normal. This immediately rules out several other causes of widespread pain, like polymyalgia rheumatica, where the ESR and CRP would be sky high, or bone metabolic disorders like Paget's disease, where the alkaline phosphatase would be elevated. If this lab detail surprised you, take a moment to rewind and review the utility of these basic tests and how they rapidly exclude inflammatory or metabolic causes of pain.
Okay. Key takeaway for diagnostics. Joint aspiration is key in acute monoarthritis. T-scores define osteoporosis severity. The CRP-ESR relationship can be paradoxical in active SLE, where a high CRP suggests infection. And remember the polarized latent MARIC. Needle-negative birefringence is gout. Rhomboid positive is CPPD.
Perfect.
Moving now to the battle plan, the principles of management. And this must always start with non-pharmacological strategies.
Absolutely. The plan must be individualized, and patient education is paramount. Patients, particularly those with conditions like osteoarthritis or chronic inflammatory disease, need to understand that while structural changes may be permanent, focused intervention can significantly improve their pain and, more importantly, their function. You have to manage expectations.
And lifestyle and exercise are powerful medicine here. Aerobic fitness training, just getting the heart rate up, is incredibly effective for long-term reduction in pain and disability across many of these conditions. For localized issues, muscle strengthening must be done frequently in small amounts often.
And we cannot overstate the importance of weight reduction for obese patients. Obesity aggravates symptoms and progression in OA and psoriatic arthritis, not just by increasing mechanical strain, but also because adipose tissue is a source of pro-inflammatory cytokines, which just amplifies the systemic inflammation.
And joint protection, which we call smart use, is about changing habits. It involves pacing activities, breaking up physical tasks into shorter segments with mandatory breaks. And here's a classic anchor for mobility aids. If a patient has a painful hip or knee, they must use a walking stick or a cane on the contralateral side.
The opposite side.
The opposite side to the painful joint. This shifts the center of gravity and dramatically reduces the load transferred across that affected joint.
Non-pharmacological interventions also include local heat or ice packs and temporary use of splints or orthosis for rest and support. But a crucial warning here: prolonged rest must be avoided.
Why is that?
Well, while it might seem intuitive, prolonged rest can lead to muscle atrophy, joint stiffness, and ultimately worsen chronic disability. We aim for mobility, but with protection.
Now for the pharmacological cornerstones, beginning with analgesia. Paracetamol, or acetaminophen, is the first choice for mild pain due to its excellent tolerability. It works primarily by inhibiting prostaglandin synthesis centrally in the brain.
Then we escalate to NSAIDs, nonsteroidal anti-inflammatory drugs. These inhibit the cyclooxygenase enzymes, KOX1 and KOX2. KOX1 is the constitutive protective one for the gut, kidney platelets, while KOX2 is induced at the site of inflammation.
And that's why non-selective NSAIDs carry risks.
Exactly, especially GI bleeding and cardiovascular events, which is why we must be vigilant, particularly in older patients with comorbidities.
Selective KOX2 inhibitors, the coxibs like celecoxib, were developed to spare the GI tract, but they come with a crucial trade-off. They are associated with a higher cardiovascular risk, especially in patients who are already at risk. The choice is a balance of GI versus CV risk profile.
Next up, glucocorticoids. Powerful, rapid, anti-inflammatory, and immunosuppressive agents. They can be given orally, intramuscularly, or intraarticularly for a local effect. They work by suppressing gene transcription for pro-inflammatory cytokines and inducing apoptosis in inflammatory cells. They are fantastic for rapid relief, but they carry major long-term side effect risks, like osteoporosis and Cushingoid features.
And this brings us to that critical clinical anchor regarding glucocorticoids, the psoriatic arthritis flare contraindication.
Yes, the crucial anchor. Glucocorticoids must be avoided in patients with active psoriatic arthritis flares. If you administer steroids, the symptoms will improve dramatically. However, when you taper and stop the drug, there is a serious risk of a rebound, often severe increase in psoriasis, skin activity, or the underlying arthritis.
That's a huge safety point.
A very common test question and a high-stakes clinical safety point that you just have to remember.
Now for the foundation of chronic management, the classical disease-modifying anti-rheumatic drugs, or CDMARDs. These change the disease course, not just the symptoms.
And methotrexate, or MTX, is the cornerstone. It's the primary CDMARD for rheumatoid arthritis, juvenile idiopathic arthritis, and psoriatic arthritis. Its mechanism involves inhibiting folic acid reductase, which limits DNA synthesis in rapidly dividing inflammatory cells, like lymphocytes. This slows the autoimmune process.
You must anchor the dosing complexity for MTX. It is dosed weekly, often starting at 10 or 15 milligrams and titrating up to 25 milligrams per week in adults. A common, very dangerous medication error is prescribing it daily.
And, because it's a folate antagonist, folic acid, 5 milligrams per week, must be co-prescribed. Critically, the folic acid should be taken the day after the MTX dose.
Why is that?
To reduce side effects like nausea, mucosal ulcers, and hepatotoxicity without impairing its efficacy against the inflammatory cells. Liver function monitoring is mandatory. And remember the pregnancy rule. It must be stopped at least 3 months before attempting conception due to its severe teratogenicity.
Other CDMARDs include sulfasalazine and hydroxychloroquine. Sulfasalazine is memorable because of a harmless side effect. It can cause orange staining of urine and contact lenses.
Right. And hydroxychloroquine is a gentler DMARD, often used in combination, and it's generally well tolerated long-term, though ophthalmic screening for rare retinal toxicity is required.
When CDMARDs fail, or if the disease is rapidly erosive, we then escalate to biologics, or BDMARDs, and targeted synthetic DMARDs, TSDMARDs.
The most common first-line biologics are the TNF-alpha inhibitors, or TNFi, like adalimumab or infliximab. They neutralize TNF-alpha, which is a key driver of inflammation and joint destruction in RA, PSA, and axial SPA.
However, using a TNFi requires careful screening for contraindications.
It does. Since TNF-alpha is central to fighting infection, these drugs are contraindicated in patients with active infections, including latent TB, which must be screened for. They are also avoided in patients with significant heart failure, NYHA grade 3 or 4, as they can exacerbate symptoms, and in patients with demyelinating diseases like multiple sclerosis, as they may trigger or worsen flares.
We also use newer biologics like the IL-17 inhibitors, secukinumab and ixekizumab. These are highly effective for PSA and axial SPA, targeting a different inflammatory pathway. But here's the second essential contraindication anchor.
They increase the risk of triggering flares of inflammatory bowel disease, or IBD.
Right.
Therefore, if you have a patient presenting with PSA or axial pain, who also has features that suggest enteropathic arthritis, you should generally avoid IL-17 inhibitors and choose a different biologic pathway, maybe a TNFI or an IL-12/23 inhibitor to prevent gastrointestinal complications.
Finally, the JX inhibitors. These are small molecules, TSD-MARDs, that work intracellularly, targeting the Janus kinase pathway that multiple cytokines use for signaling. They are effective and fast-acting, administered orally, but are typically used after CDMARDs have failed due to concerns over slightly higher risks of venous thromboembolism and infection compared to older therapies. Let's use rheumatoid arthritis as our management pathway example, integrating these principles. The primary goal is not just symptom control, it's to achieve remission or low disease activity as quickly as possible. The treat-to-target approach to suppress inflammation and prevent irreversible joint damage.
That treat-to-target concept is absolutely vital. You start promptly with a CD-MARD, nearly always methotrexate. Since NTX takes 4 to 8 weeks to become fully effective, you need a bridging therapy.
Which is usually steroid.
Usually a short, reducing course of oral glucocorticoids, maybe starting at 15 to 30 milligrams daily and tapering off as the MTX starts to kick in.
And if the patient isn't achieving low disease activity after 3 to 6 months, if they aren't meeting the target, the strategy escalates. The next step is often triple therapy, combining MTX with sulfasalazine and hydroxychloroquine. This utilizes different mechanisms to achieve deeper suppression.
And if triple therapy fails, or if there are prognostic factors for aggressive disease like a high ACPA titer, that's when you pivot to a biologic, a BD-MARD, or a targeted synthetic, a TSD-MARD, often a TNFI.
How do you monitor this?
We monitor activity using the DANS-28, the Disease Activity Score 28, which combines the number of swollen and tender joints out of 28, inflammatory markers like ESR or CRP, and the patient's subjective global health assessment.
And a DAS-28 score of less than 2.6 indicates remission. The goal is to keep them there.
Right. And we must revisit the critical detail of pregnancy considerations. Many RA patients experience natural remission during pregnancy due to hormonal and immune shifts. While sulfasalazine and hydroxychloroquine are generally considered safe throughout, MTX and leflunomide must be stopped months prior to conception due to their severe teratogenicity. The timing and the transition plan here are life-altering decisions that require meticulous planning.
Key takeaway for management. MTX is the foundation, dosed weekly with folic acid the next day. Glucocorticoids are a crucial bridge, but contraindicated in PSA flares. And biologic choice, like TNFI versus IL-17 inhibitors, requires a critical review of non-rheumatic comorbidities like heart failure, MS, and IBD to avoid serious complications.
That's the essence of it.
Let's dedicate some serious time now to the acute arthropathies, starting with gout. The uric acid crisis.
Okay, the pathophysiology anchor here is that gout is caused by hyperuricemia serum uric acid, or SUA, above 400 micromoles per liter in men, which leads to the deposition of monosodium urate crystals in the joints.
But here's the critical distinction. Being hyperuricemic is not the same as having gout.
Absolutely not. Only a minority of hyperuricemic individuals actually develop the disease. That's because crystal formation is dynamic, and it depends on local factors like temperature, pH, and the concentration of natural inhibitors. The primary mechanism underlying hyperuricemia in over 90% of gout patients is reduced renal excretion of uric acid. The kidneys simply don't clear enough of it.
Increased production is rare.
Very rare, seen only in specific genetic enzyme defects or high purine turnover states, like after chemotherapy.
The triggers and risk factors are common clinical knowledge, and they center on disrupting that balance. Metabolic syndrome, high alcohol intake, especially beer, purine-rich diets like seafood and organ meats, and drugs like thiazide diuretics, which reduce renal excretion.
And clinically, the attacks are explosive. Acute onset, severe pain, marked synovitis, redness, swelling. They are characteristically self-limiting, resolving on their own over 5 to 14 days. The classic location is the first MTP joint presentation we call podagra.
And the definitive diagnosis, as we anchored earlier, is joint aspiration showing those long, needle-shaped MSU crystals with negative birefringence.
Acute treatment focuses on rapidly terminating the massive inflammatory response that's triggered when those crystals are phagocytosed by immune cells. Colchicine is the gold standard, often given at 0.5 milligrams, 2 to 4 times daily initially.
And its mechanism is fascinating.
It is. It inhibits microtubule assembly in inflammatory cells, which effectively stops the cell-mediated inflammatory cascade. It particularly inhibits the inflammasome, which reduces the key inflammatory cytokine IL-1 beta.
NSAIDs are also an option.
Highly effective, but you have to use them cautiously in older patients due to renal and CV risk. Oral glucocorticoids, maybe 15 to 20 milligrams daily for a few days, or an intra-articular injection, are often the safest and most effective choice in older patients or those with renal impairment, where NSAIDs or colchicine might be too toxic.
The long game is prophylaxis using urate-lowering therapy, or ULT. This is required for recurrent attacks, more than one per year, or complications like visible tophi, which are large urate deposits or joint erosions. The therapeutic goal is deep suppression of the SUA, typically targeting less than 360 micromoles per liter to dissolve existing crystals, and potentially even lower, less than 300, if the patient has tophaceous gout.
Allopurinol is the first-line ULT. It's a xanthine oxidase inhibitor, which means it reduces the production of uric acid by blocking the final enzymatic steps in the purine pathway. The dosing strategy is crucial. Start low, maybe 50 to 100 milligrams daily, and titrate up slowly, sometimes to very high doses, monitoring the SUA levels every few weeks until the target is met.
Now, here is where we address that crucial clinical complexity. You mentioned earlier that starting allopurinol can actually trigger a painful flare. Wait, so we're prescribing a drug that we know might cause a painful attack just to fix their SUA long term? That sounds incredibly counterintuitive. How do we manage that inherent risk?
That's an excellent question, and it's where many students, and frankly many patients, get tripped up.
Yeah.
It happens because the rapid change in the SUA concentration, even when it's dropping, can destabilize existing microtophi. This causes a shedding of crystals into the joint space, which triggers a massive acute inflammatory response.
So this is the critical anchor for ULT initiation.
It is. Patients must be warned about this predictable flare. They must be instructed to continue the ULT, whether it's allopurinol or febuxostat, through the flare. And they must be co-prescribed prophylaxis, either low-dose oral colchicine or an NSAID, to be taken continuously for the first 3 to 6 months until the SUA is stabilized at the target level. Stopping the ULT during a flare is the single biggest management mistake.
Right, so the key takeaway for gout. Gout management requires both rapid acute control with colchicine or steroids and meticulous long-term prophylaxis with allopurinol. But remember the dangerous paradox.
Ooh.
Watch out for the flare when starting ULT, and always co-prescribe prophylaxis for the first several months to avoid catastrophic patient non-adherence. Now for the second sharp invader. Calcium pyrophosphate deposition disease, or CPPD, often dubbed pseudo-gout because it mimics gout so closely.
CPPD is characterized by the deposition of calcium pyrophosphate crystals. Unlike gout, CPPD risk factors are heavily linked to conditions that disrupt calcium and phosphate metabolism and matrix stability. Key risk factors are simply increasing age, coexisting osteoarthritis, and metabolic issues like hyperparathyroidism and hemochromatosis, or iron overload.
So workup for secondary causes is mandatory.
Absolutely. The clinical presentation is highly variable. It can manifest as acute arthritis pseudogout, often affecting larger joints like the knee, wrist, ankle, and shoulder. But it can also present as a chronic, debilitating arthritis that's just superimposed on existing OA symptoms.
And there's that specific syndrome.
Yes, a memorable one associated with CTPD is Crown-Dens syndrome, which is caused by CPP crystal deposition and inflammation around the odontoid process, the dens, in the cervical spine. This causes severe, often sudden neck stiffness and occipital pain, which can sometimes be mistaken for meningitis or polymyalgia rheumatica.
Diagnosis relies, again, on joint aspiration, showing the smaller rhomboid or brick-shaped crystals with positive birefringence. X-rays may also provide a critical clue. Chondrocalcinosis, visible calcification of the hyaline cartilage or fibrocartilage, often seen in the minutiae of the knee or the triangular fibrocartilage of the wrist.
And management of the acute attack is similar to gout. Intra-articular glucocorticoids are often the safest and most effective option, followed by NSAIDs or colchicine. Crucially, because CPPD is common in older, sicker patients, it must be noted that sepsis can coexist with CPP crystals.
A huge point.
Never let the finding of crystals dissuade you from performing a Gram stain and culture of the synovial fluid. Septic arthritis is still the #1 differential you must exclude.
Okay, key takeaway for CPPD. CPTD should be suspected in older patients presenting with acute inflammation superimposed on OA. The crystals are rhomboid and positive. Always exclude septic arthritis and diligently screen for secondary causes like hyperparathyroidism or hemochromatosis.
We transition now to osteoporosis, the most common bone disease globally, and a public health crisis often termed the silent thief, because it only announces itself when catastrophe strikes, a fracture.
The defining feature is a reduction in bone mineral density, or BMD, leading to microarchitectural deterioration. This means the scaffolding, the trabecular bone, loses its integrity, leading to fragility fractures, a fracture resulting from a fall from standing height or less.
The risk increases exponentially with age, but it rapidly accelerates in women post-menopause due to the loss of estrogen.
Right.
Pathophysiologically, age-related bone loss is rooted in that remodeling imbalance we discussed back in Section 1. After about age 40, the new bone formation by osteoblasts simply cannot keep pace with the amount removed by the osteoclasts. We also see a reduction in the number of active osteoblasts, partly because the progenitor marrow stromal cells preferentially differentiate into adipocytes or fat cells instead of osteoblasts as we age. The construction crew shrinks and slows down.
And we must anchor glucocorticoid-induced osteoporosis, or GIOP, a massive cause of secondary osteoporosis. If a patient is taking more than 7.5 milligrams of prednisolone daily for more than 3 months, they are at significant risk.
And the mechanism of GIOP is distinct from age-related loss. Glucocorticoids primarily cause osteoporosis by profoundly inhibiting bone formation, not just increasing resorption. They do this by accelerating the apoptosis, the programmed death of the osteoblasts and the site managers, the osteocytes.
They kill the construction crew.
They kill the construction crew, which is far harder to reverse than simply inhibiting the demolition crew.
Clinically, the disease is an asymptomatic deterioration until that fragility fracture occurs. Vertebral fractures are the most common, causing chronic back pain, height loss, and kyphosis. But the hip fracture is the most devastating.
The mortality is staggering, about 12% immediately and a 20% continued increase in mortality compared to age-matched controls in the year following the event.
That's staggering. It highlights why we call osteoporosis the silent thief. It's not just a quality of life issue. It's a profound threat to longevity.
And here is a major clinical anchor point for the learner, something that surprises many students. When analyzing fracture populations, the majority of people suffering a fragility fracture have osteopenia, not osteoporosis. Their T-score is between -1.0 and a -2.5.
How does that work?
It's a critical statistical concept. Well, the risk of fracture is highest in those with defined osteoporosis, so a T-score of -2.5 or lower. The sheer volume of people categorized as osteopenic in the general population is so much larger that they account for more absolute fractures. You cannot dismiss osteopenia in a high-risk patient.
Right. Diagnosis relies primarily on DXA scanning. It's recommended for all patients over 50 who have suffered a fragility fracture, or in younger patients with strong risk factors like premature menopause, chronic malabsorption, or most commonly high-dose glucocorticoid use. We also use fracture risk calculators like FRAX to integrate the BMD with other clinical risks.
And the management goal is unambiguous: reduce fracture risk. Lifestyle modifications like weight-bearing exercise, adequate calcium, and vitamin B supplements, they're supportive but often insufficient alone. Pharmacologically, we divide agents into anti-resorptive, which slow breakdown, and anabolic, which stimulate building.
Bisphosphonates like alendronate or zoledronic acid are the most common first-line anti-resorptive treatment. Their mechanism is ingenious. They target active bone surfaces, are ingested by the osteoclast during resorption, and once they're inside the osteoclast, they inhibit key metabolic pathways, leading to osteoclast apoptosis or cell death. This suppresses resorption and allows net bone density to increase.
Anchoring the side effects and the practical dosing is crucial for the oral bisphosphonates. They're poorly absorbed, so the patient has to take them on an empty stomach with plain water and then remain upright for 30 to 60 minutes to prevent painful esophageal irritation and reflux.
And the IV infusions?
IV infusions, like zoledronic acid, which is often given annually, they bypass the GI tract, but can cause a systemic but self-limiting acute phase response fever, malaise initially.
And there are two rare but serious long-term side effects to know. First, osteonecrosis of the jaw, or ONJ, typically following invasive dental procedures. The risk is higher with IV bisphosphonates or high doses, but patients should always inform their dentist.
And second, atypical subtrochanteric fractures of the femur, which occur because long-term complete suppression of remodeling can actually make the bone too brittle, leading to stress fractures. This is why we often consider drug holidays after about 5 years of oral use or 3 years of IV use, followed by a review.
Then we have denosumab, a monoclonal antibody administered subcutaneously every 6 months. It works by neutralizing ARO-NKL, the go signal for the osteoclast, essentially preventing the demolition team from ever starting work. It is highly effective, but has one critical anchor that separates it from all other treatments.
And that is the bisphosphonate chaser. If denosumab is stopped, the suppression of RNKL ceases immediately. Since the osteoclast precursors have been accumulating without maturing for 6 months, there is a severe rapid rebound increase in bone turnover, which significantly increases the risk of multiple vertebral fractures within
So
months.
you cannot just stop it.
You cannot stop denosumab and walk away. If a patient must discontinue denosumab, they must immediately transition to an anti-resorptive agent, usually a bisphosphonate like fine-zoledronic acid, to inhibit that catastrophic rebound phase.
Yeah.
That bisphosphonate chaser is mandatory.
Lastly, we have the anabolic agents, the bone builders. These are generally reserved for severe high-risk cases, like those who have failed anti-resorptive therapy or those with GIOP.
Right. Teriparatide, a synthetic fragment of parathyroid hormone, and abaloparatide are fascinating because they stimulate osteoblast activity, shifting the balance entirely toward formation. They are used for a limited time, typically 18 to 24 months, because of the mechanism and cost. After the anabolic window closes and significant bone has been built, the patient must be followed by anti-resorptive therapy to maintain those gains.
And the newest anabolic agent, romosozumab, is highly effective. It stimulates formation and inhibits resorption simultaneously. However, it carries a slight associated cardiovascular risk and is therefore contraindicated in patients with a recent history of a heart attack or stroke.
So the key takeaway for osteoporosis: treatment is a long game requiring strategic drug use. Anti-resorptive agents like bisphosphonates and denosumab slow breakdown. Anabolic agents like teriparatide and romosozumab stimulate building. Discontinuing denosumab requires a bisphosphonate chaser to prevent dangerous rebound vertebral fractures. And never forget that the majority of fractures occur in the osteopenic population.
We've truly covered massive ground, moving from the microscopic bone construction crew to the macro management pathways of these complex diseases. Let's synthesize the most important anchors for your immediate recall, the knowledge you absolutely need to carry into your clinical rotation.
First, remember the bone remodeling crew: osteoclasts and osteoblasts. The master switch for resorption is a ratio of the go signal RNKL to the blocker OPG. Bone formation, which is Wnt signaling, is inhibited by sclerostin, or SOST, which is the signal that gets switched off by mechanical loading linking mobility directly to bone maintenance.
Second, in diagnostics, always perform joint aspiration in acute monoarthritis to exclude the catastrophe of septic arthritis. Use polarized light to distinguish the negative needle-like urate crystals of gout from the positive rhomboid CPPD crystals. This is non-negotiable diagnostic knowledge.
Third, treating chronic inflammatory disease is about early aggressive intervention, the treat-to-target approach. Rheumatoid arthritis requires MTX as its foundation, bridged by glucocorticoids, and the choice of biologic therapy demands that you integrate non-rheumatic comorbidities, avoiding IL-17 inhibitors if there is an IBD risk, or TNFi in significant heart failure or MS.
And finally, osteoporosis treatment must be strategic and nuanced. Be aware that the majority of fragility fractures occur in people with osteopenia, so risk assessment matters more than just the T-score definition. And if you inherit a patient on denosumab, never, ever let them stop it without immediately prescribing a bisphosphonate chaser to manage the vertebral fracture rebound risk. That is a clinical must-do.
If the anatomy or the crystal sections felt blurry, we strongly encourage you to immediately replay those specific segments now to truly embed those distinguishing features. That clarity will save you minutes in a high-pressure clinical situation and protect your patient.
So as we close this deep dive, let's leave you with one final provocative thought that ties the whole system together: bridging your knowledge of anatomy and systemic disease. We discussed how mechanical loading inhibits sclerostin and promotes bone formation. Given that physical immobility is tragically common in chronic illnesses, whether due to crippling pain in RA, severe fatigue in SLE, or prolonged hospital stays for any reason, how much of the systemic bone loss and accelerated osteoporosis seen across all these diverse pathologies is driven not just by local inflammation or specific drug effects, but by the fundamental failure of those site managers, the osteocytes, to sense and respond to the lack of normal daily mechanical stress.
The profound connection between systemic disease, a sustained lack of movement, and the active destruction of the bone matrix warrants deep critical thought as you move forward into clinical practice. Thank you for joining us for this deep dive.
I'll see you next time.